Welcome to the Compounding Center Connections, where we talk about different health conditions with our partnered practitioners. I'm your host, Jay Gill, a compounding pharmacist from the Compounding Center in Leesburg, Virginia. At the Compounding Center, we collaborate with practitioners, create custom medications to help patients with their healthcare needs. The information discussed today is for informational purposes only, not for diagnosis. In today's episode, we have Jim Paoletti, an independent clinical pharmacist. He's part of our Compounding Center team here, and Jim has over 30 years of experience with bioidentical hormone replacement therapy in clinical practice, as a consultant, and as an educator. Jim, can you please introduce yourself to the viewers and listeners?
Hi, glad to meet you all. I have been doing this now. This is my 40th year, Jay.
Oh, wow.
I'm much older than I look, I know. I'm also trained in functional medicine. I had the privilege of being on the faculty of the first fellowship of functional medicine and got to take the classes. So I use a lot of that training in my consultations along with the basic hormones.
So just to let our viewers and listeners know, Jim is off-site, but we have worked with Jim for many years, and all the clinical concepts that get referred to us, Jim, does all the consultations. So let's get started. We've decided to do a series of podcasts with Jim, so please subscribe to our channel to listen to our future topics. In today's discussion, we're going to talk about progesterone, its use as topical or oral, or can women do both? So, Jim, just to get kind of backtrack a little bit, could you tell us what is progesterone and its main function?
Oh, so many functions of progesterone in the body, it's kind of tough to come down to a main one. But I think overall you'd have to say it's interaction with estrogen. There are places in the body where progesterone enhances the estrogen activity, such as cardiovascular protection, lipid profile. There are places where it's countering or balancing it, like reducing proliferation in the breast tissue and the uterus. And then there are places where progesterone regulates what estrogen does, such as the formation of cartilage in skin tissue and in bone formation. So I would say their main function is its interactions with estrogen.
Okay. All right. And can you tell us the difference between bioidentical progesterone and progestin?
Okay, the term progestin, we use it a little bit differently clinically than what it is by definition. Progestin is anything that works on the progesterone receptor. So technically, progesterone is a progestin in that sense, but we differentiate it this way. Progesterone itself is bioidentical, which means its molecular structure matches what the body always produced itself, where a progestin is anything else, any structure that does not match what progesterone structure is. And the difference is night and day. Progestins work just like progesterone in the uterus. However, that's the only spot in the body they do that. Outside the uterus, they produce the opposite effect of natural progesterone.
Okay. So example of a progestin would be medroxyprogesterone. An example of a natural progesterone would be what we compound, progesterone capsules, and Prometrium is the other manufactured brand name of progesterone that's available. Right?
Huge difference there between the Prometrium or the generic Prometrium and the compounded progesterone and this. When we compound it, we sustain release it. Women can take it once a day and maintain that level pretty much around the clock. The progesterone capsule and oil, the manufactured product, is not slow released in any way. It's immediate release. It's going to release it in the bloodstream quicker. You're not going to bind as much. It's metabolized quicker. Bottom line, it does not maintain a progesterone level 24/7. So if you're on estrogen of any kind, cream or patch, you're going to have an estrogen level 24/7. You're not going to have the protection offered by progesterone around the clock. So that's why I do not use the manufactured progesterone capsule.
Okay. All right. Thank you. Now, how about we talk about what are some symptoms of a person having low progesterone levels?
Okay, well, think most commonly about the perimenopausal woman because that's the first hormone she loses, progesterone. And she's going to have what? Heavy, irregular cycles. She's going to have breast tenderness because the proliferation of the estrogen on the breast tissue and no longer having a progesterone to prevent that. She's going to have PMS symptoms, cramping, bloating, headaches, etc. She's got weight gain. Estrogen is central nervous system stimulant, so and progesterone calms the system. So lack of progesterone, anxiety, headaches, poor sleep, and yes, lack of progesterone, even when there's estrogen on board, will cause hot flashes because progesterone affects the estrogen receptors. So estrogen doesn't function correctly if progesterone is not on board.
Okay.
It also
And
causes infertility, acne, and a whole list of things.
gotcha. And so you have all these symptoms. You kind of have an idea, hey, these are, some symptoms of low progesterone, but then hopefully you do some tests to match symptoms with some results. Uh, Tell us a little bit about what's your methodology on testing. There's saliva testing, there's urine testing nowadays, and blood testing. So how do you go about, or where do you look? What's your opinion on the test?
Well, first of all, when you say blood, you have to differentiate because there is serum testing, which is conventional blood draw from the arm. That's venous blood versus the capillary blood where you prick your finger. And there's a world of difference there. All these have their place. I can use serum testing for the basic baseline levels. If a patient's not using hormone therapies, you're going to, for the most part, you can't use serum androgens for women because the tests were developed for males and are not sensitive enough for women. But if I need to know her estrogen and progesterone, she's already had serum tests. If she's not on hormones, I can use those numbers. But once you get on hormones, now you're going to run into problems, especially if you applied it topically. Topical hormones will not show up in the venous serum. Okay, they will in capillary blood, but not the venous serum. I don't use much urine for hormone monitoring. Again, I can, if you have a urine test done, I can get a baseline and that works. But once you start supplementing hormones, urine measures metabolites, not the hormone itself. What I want is a test that represents how much of this hormone itself am I getting at the tissue, at the receptor where it works. Now, urine's great for measuring estrogen metabolism to make sure you're safely metabolizing them, for measuring neurotransmitters, heavy metals, measuring your iodine. I mean, it has its place. But if we want to talk about monitoring hormone therapy, I'm going to use saliva most often. And the other advantage of saliva, two. One, I can get a good representation of cortisol throughout the day. It's the only way I can really, that urine are the only two you can do that. Can't do that in serum. And two, I'm going to give a representation of the free hormone. The hormones can be bound or they can be unbound or called free. That's what works at the receptor. So what I want in a test is give me a representation of the free hormone in the tissue where it works. And I think saliva does that best. Now, I've said I can use the others for baseline, but if I'm going to monitor down the road in 6 months, I would prefer to have as a baseline the same test I'm going to use in 6 months. Most women are getting on a topical hormone. We're going to have to use saliva. So that's why I prefer to use saliva for the most part to start out too.
Gotcha. So this would be a great time to talk to us about oral progesterone versus topical progesterone. When does are both okay to use together, or is one better than the other? Tell us a little bit about oral versus topical progesterone.
I don't like to say one is better than the other. Each has certain advantages. If a woman's on an estrogen cream and she wants to use progesterone 2 or needs to use progesterone 2 and put it in the same cream, that's going to be more convenient, more economical. However, oral progesterone, compounded slow release, has a couple of distinct advantages. Number one, in a perimenopausal woman who's still cycling, you want to try to mimic what the body does, get the progesterone up quickly on day 14 and then drop it off really quickly when the estrogen drops off to initiate that cycle. So to best regulate the cycle, you're going to use an oral progesterone rather than a topical because oral is going to get in much more quickly. And When you stop it the next day, 24 hours, it's gone. In a cream, it takes time to build up, and you can stop a progesterone cream on day 28 and it could still be there in traces 4, 5, 6 days later. So regulating cycles. The other real advantage, and this is why I use a lot of oral progesterone. Jay, you know this, how many patients do we see that aren't sleeping well?
Yeah.
A majority, right? When you take oral progesterone, you produce more of the metabolites 4-allopregnanolone, 5-allopregnanolone, which are GABA agonists, which means they work on the GABA receptor. GABA is an inhibitory neurotransmitter that causes calmness and relaxation of the mind. So the side effect, quote unquote, that you will see in a majority of women taking oral progesterone is they sleep better. So when I offer women their choice, you can do this topically, you can do it orally, that would require a separate script. They always want that better sleep.
Mm-hmm.
Now you can switch them later. You get everything worked out. You get the cortisol that's causing poor sleep under control. You get the estrogen dominance under control. Yeah, you can switch later to topical. Either one works. But that's when I use oral. Regulate cycles and better sleep.
And do you get the same endometrial protection with both dosage forms, or is it only with topical? Can you?
No, actually, if you think about it, Jay, Prometrium was approved by the FDA for one purpose: endometrial protection. So it's absolutely accepted that the oral works. What hasn't been accepted is that topical works. It does. There was a review study done years ago, and where they looked at all the studies where topical progesterone was claimed to or not to protect the lining. And what they discovered in 6 studies that said topical progesterone does not protect the lining, they simply looked at serum values and said they're not high enough to offer protection. Again, serum values are not valid with topical hormone. Okay. There are 2 studies out there, one by Helene Leonetti, and I'm sorry, the author of the other one, but they both did topical progesterones at 20 milligrams a day to women that had high estrogen stimulation, Premarin estrogen orally. And 20 milligrams a day protected the lining. The way they discovered this was they did a biopsy and looked at the tissue and say, did we get the objective we were after? Absolutely. So this review study came to the conclusion that you cannot use the serum numbers to judge the clinical effectiveness of topical progesterone. Bottom line, you're right, both work, both provide the protection, but I find physicians are much more willing to take my recommendations with oral progesterone if the woman still has a uterus.
Now, I'm also seeing some practitioners will use we call it topical progesterone, but it can be also used intravaginally. And what are your thoughts on that?
It works. All the hormones can be applied vaginally. I think there's minute differences when you're applying to the mucous membrane. You're going to get a little bit faster absorption, and the quicker hormone goes in, the quicker you're going to metabolize it. So it may, let's say you're dosing it once a day compared to topical once a day. It may take a little bit more hormone vaginally sometimes. In rare cases, sometimes I have to go to twice a day dosage, but as far as working, it works. Works fine.
Okay.
I most of the time I give women their choice if they want a vaginal application or topical application. Either one works.
Now, Jim, is it always taken with estrogen, or to balance the estrogen, or can it be taken by itself too?
Well, both ways. If you've got a woman that's perimenopausal, she's still making her estrogen.
Yeah.
And so you're giving it. You don't have to give estrogen. The woman's making it already. Now, if you got a menopausal woman who's making no estrogen, no, you need to give her some estrogen. One of the functions of estrogen when it works on the DNA is to make progesterone receptors. If you have no estrogen there, you don't have the progesterone receptors for the progesterone to work on. So progesterone, estrogen, remember I said the main function of progesterone is its interaction with estrogen. You have to think of it yin and yang. Everywhere in the body where estrogen works, progesterone works there too. And they're meant to work together. So you don't really want to be deficient in either hormone.
Okay. Now, in addition it's used in conjunction with estrogen for menopausal women, and then perimenopausal, by itself. Any other, conditions that progesterone is very useful for?
Well, we can use it in younger women with with PCOS, PMS,
Yeah.
those type of problems where the progesterone level is low. And I think that helps a lot. But I do want to say that conditionally. If you're going to do a functional approach as well as a holistic approach, you need to ask yourself why maybe this 18-year-old has PCOS, why this 16-year-old is having such severe PMS. You need to look at stuff like insulin resistance developing in these young women. I don't care what their weight and height is. Look at their eating habit and their exercise or lack of. Insulin resistance, as it first develops in the body, long before you'll see numbers change in the liver, which say there's a problem, will affect ovarian production of hormones. It messes with the LH FSH surge, which now can do a small constant stimulation daily and produce PCOS. So yes, that woman is low on progesterone. I want to give her progesterone, but I need to get her on an anti-inflammatory diet, maybe some fish oil, get the inflammation down for these symptoms, and I need to get the insulin resistance corrected. So it's useful. It can help with the symptoms a lot, but you have to correct the underlying cause of why a woman would be deficient at an age she shouldn't be deficient. Hormone replacement should be done with that thought in mind. It's intended for when physiologically a woman is no longer producing a sufficient amount. In anybody else that should be producing a sufficient amount, you need to ask why they're not and fix the underlying problem at the same time you give them the hormone. And a lot of times in those younger women like that, the progesterone's temporary. Maybe 6 months while we fix the underlying cause, and then they don't need the progesterone anymore.
Gotcha. Now, Jim, talk to us a little bit about your consulting practice, how you manage patients, how you handle a new patient that is reaching out to you.
I've been doing this for so many years. I'm still developing the process. I'm presently consulting with Leesburg, the compounding group there, but I'm also consulting with a pharmacy here in Columbus, Ohio, where I reside. I'm also consulting with a group in California, a pharmacy in Louisiana, and a pharmacy in New York City. So I've taken the different processes those stores use and try to meld everything into one process. But the bottom line is, I don't try to require up front, oh, everybody does this testing. Everybody gets me this information. No, I do it on an individual basis. I have a health questionnaire that I provide to patients, and I have them fill that out. And it's pretty detailed. I'm asking what your dietary intake is every day, what your exercise is, what your medical history is, what your gynecological history is. And I'm going to ask you, most importantly, a whole page of symptoms. I want you to rate them. And doing it this many years, you can pretty much, after that many years of experience, look at the symptoms to tell what's wrong with the patient. But what I do then, based on that individual, I say, okay, here's what we need, here's what we know, here's what we don't know. How do we find that out? And I will talk with the patient about, here are your testing options. We can go this route and do everything in saliva, this much money. We can do this much in saliva, what we have to do there, and the rest we could do in serum. It's going to be this much money. And then I let the patient, I explain why I have my preferences, but it's the patient's choice as to which way we go forward. My job is to take the wisdom I've learned from all those years of experience and training and help the patient make a good choice. So I call it a very individual approach. It's so different. And that's why, I've had so many people who do what I do, who've been doing it a long time, ask me, aren't you tired of this, Jim? I said, no. I said 40 years, and I still, this year, I can tell you a dozen patients off the top of my head that are so different than anybody I've ever seen. So that I keep that in mind, every patient, what they can afford, what they need to do, their history, that's them. And so I just take an individual approach. And what I do when I get all the information I need, we'll set up a virtual meeting, or if they're in Columbus, I'll see them live. We can do a phone consult if they don't want to have me see them on the screen. Whatever the patient chooses, again, patient's in charge, not me. But I'll sit down, I'll do a consultation in which I go over their questionnaire, make sure I understand everything completely, ask a few more questions, always have more questions. And then it's because we're playing hormone detectives is what we're doing. The more clues, the better. So I'll ask more questions, but then I'll take their test results and their symptoms, I'll correlate the two, and I'll come up with a plan of care. which will include recommended prescriptions, over-the-counter supplements, lifestyle adaptations, chapters or whole books to read, more testing they should consider doing in the future. Again, it changes with every person. Then I'll type up a report to their doctor, and send it with my recommendations for the scripts right in there, typed out for the doctor, just 1-page synopsis of what's going on with the patient, my recommendations and why. And then the prescriptions on the second page, all they have to do is sign off on and fax it back to your pharmacy, make it as easy as possible. And then I will include automatic follow-ups with patients. Most of the stores I work with say the initial fee includes 2 follow-ups. I basically, unless you abuse the privilege, I will follow up with you as long as I need to for 6 months for no additional charge. That way the other thing that's really important to remember if you're doing this, patients respond so differently to OTCs, to prescriptions, to dosages. Most patients you're going to have to tweak a little bit to really get them feeling good. So, I'm assuming that I might have to tweak 7 weeks out. And then if I tweak them 7 weeks out, I'm going to follow up with them another, 2, 3, 4 weeks and say, hey, did that work? Or do we have to do something else? So quite common, I do short follow-ups, which can be done by email and phone sometimes virtual meetings. But basically, I just tell patients, once they sign up with me, they're stuck with me until I get them feeling good.
Well, one thing I do want to clarify for everyone is that we still do need a prescription from their physician. So Jim will write the recommendation and the prescriptions, and your physician or OBGYN has to sign off on the prescription. So the physician is always kept in the loop of any changes or in the whole treatment plan. So if you'd like to reach Jim, he can be reached at consults@compoundingcenter.com. Thank you for tuning in to the Compounding Center Connections podcast. We hope the information presented today is helpful to you or someone you know. If you have any questions or comments, please feel free to reach out to me at j@compoundingcenter.com. Subscribe to our YouTube channel and our podcast channel, The Compounding Connections, and stay tuned for future episodes with Jim Paoletti, our home run consultant at the Compounding Center.
Thanks, Jay.